Hi, Adult Health 1 or Adult Health 2, whatever you guys are. We are going to be talking about the post-op patient. This is chapter 17. This is the last chapter in your module 1. Here are your readings. Here are your objectives. So first we're going to talk about PACU. PACU is where we roll our patient out of the OR after their procedure. PACU stands for Post Anesthesia Care Unit. Um, the thing that really sets PACU apart, essentially makes PACU PACU, is how closely monitored your patient is going to be, right? We're going to strap them to, all the monitors, get everything going. We are monitoring for any complications related to surgery, respiratory depression, um, any adverse events related to anesthesia, reactions, anything like that. Um, let's see. Basically, we want to make sure pain is controlled. We are trying to avoid any complications. If your person had an abdominal incision and now has sutures in, we don't want that person violently vomiting because they're going to run the risk of blowing out those sutures, right? So PACU is all about stabilizing that patient, preventing complications, and getting that patient ready to either transfer to an in-unit situation. Maybe they get to go directly home, whatever the case may be, but making sure that we discharge a stable person. So phase 1 of PACU is pretty much what we think about related to PACU. It's that close monitoring, right? We're watching all the vitals, we're monitoring our patient's level of consciousness, we're making sure that they are returning to as close to baseline as possible and that we can safely discharge them to wherever they're going. Phase 2 is preparing for discharge. That would be like making sure that they have written instructions, that follow-up appointments, they understand all of that. Probably going to be a family member there helping to ensure that all of that stuff is in place. And then phase 3 is just extended observation. So that just means that our person is ready for discharge. They are good to go, but maybe we're waiting for a bed, or we're waiting for, a bed on a unit or a bed in a rehab or something like that. Maybe their ride can't come till the next day, whatever the case may be. They're prepared for discharge. They're good to go. They just haven't discharged from the unit yet. So PACU settings, this can be inpatient PACU, like specifically a PACU. ICU can be set up as a PACU as well. The CV OR at Banner Desert rolls straight out to their CV unit. So essentially, their CV-ICU is the PACU for any of their CV surgeries, right? Because it just rolls straight out. So we can also have outpatient PACU. Our person is there for, just for the surgery, discharging home, all of that. And then, of course, procedure areas can operate as a PACU as well. This is home discharge criteria for the PACU. Basically, this is too small for me to read right now. But we want to make sure our person is as close to baseline as possible and that we can have a safe transfer out, right? I want to make sure that my person is basically no longer under the influence of anesthesia. They are able to walk safely if they were able to walk safely before. They're voiding. I like my person to have at least 30 mils of urine out per hour. I want to make sure that I am not worried about a bowel obstruction. I am hearing bowel sounds. My person has passed gas, whatever. If they have an incision, I want to make sure it's nice, clean, and dry. The skin is intact. There's no areas of dehiscence. Dehiscence is where, we take an incision and we close it together, and it should look nice and pretty, right? Should should look nice, straight line, nice and pretty. Dehiscence is where that incision starts to pull apart, okay? And we don't want areas of dehiscence, obviously, because usually that indicates that there is some sort of infectious process going on, because it's related to the inflammation at the site, that skin is not healing appropriately. There's multiple reasons you can have dehiscence, but anyway, we want to make sure that the site clean, dry, looks pretty. Um, we want to make sure that we've avoided any adverse reactions or complications. Do all the patient teaching. Make sure that if if they speak another language as a primary language, that their instructions are in that language. We always give written instructions to people before they DC. Make sure that those are appropriate. This just talks about handoff care from the OR to the PACU. We want to know, the OR needs to tell the PACU about any complications. We know we need to talk about blood loss. We need to talk about any vitals that maybe went a little wacky, anything like that. Temperature, was patient temperature maintained throughout, or were there any hyper or hypothermic episodes? Anything that stood out. Okay. Also in handoff, we want to talk about any drains that were placed. A lot of times after surgeries, we'll put drains in to help get some of that fluid from the inflammatory process out of there quicker, right? So we need to know if drains were placed, location, all of that stuff. Priority assessments in PACU, nothing really crazy, right? All the things that we would think: respiratory, vitals, neuro, temperature, skin. We're going to want to look at skin, because depending upon how long our person was on the table, and and other health factors, did they have skin breakdown or injury related to being on that table? So we're going to do a full skin assessment. Obviously, pain, it's really important that we pre-medicate for breakthrough pain, as well as just our pain plan, right? We're going to look at those incisions, we're going to look at those dressings. We want to know what tubes and lines our person has. Do they have a Foley? Do they have an IV? What do they have going on? Pain management considerations. We talked about pain management extensively in semester 6. You want to treat pain before it becomes severe. It is way easier to keep a patient at a level 5 than it is to try to get a patient who has hit a 10 out of 10 pain scale and try to back them down. Okay. It's a much easier task to just keep someone nice and steady. So treat pain before it becomes severe. We want to talk about pain goals with our person, pain terminology, explain the scale. If they have a PCA, we want to make sure that they know how to use it. We want to know any fears they may have related to pain. The book talks about multimodal pain regimens, and that just means like using all the different things. Last semester we talked about alternative therapies. So multimodal would be your pain meds, but also alt therapies. Does music help distract you? Does television help distract you? What actually works? This just talks about, what does a stable patient look like? Really, we want our person back to baseline. Neurologically, if they were ANO times 4, we want them ANO times 4. Vitals, we want to be within normal limits, or within normal limits for that patient, right? Peripheral pulses, we want a nice strong pulse. Urine output, 30 mils per hour at least. That's, kind of our generalized what we're looking at. Pain should be controlled. Skin should look good. I should not have any new wounds. And as far as the incision is concerned, it should look nice and pretty. Complications post-op, respiratory depression, probably our biggest one, right? Blood loss. You know, even after we've rolled our person out of the OR, blood loss is still a possibility. So we need to make sure there's no signs and symptoms of active bleed, and or are those vitals indicating to me that my person might be hypovolemic, right? We talked about neuro. Some of the problems with neuro status post anesthesia is that if people went in with any sort of cognitive impairment, or our older people, or people with renal or kidney issues, they're the same thing. Liver or kidney issues, that's what I was aiming for. You know, people who can't clear the anesthetic from their system as efficiently as we would like, sometimes you end up with residual neuro complications related to the use of that anesthesia. So we worry about that. Thermoregulation. People can have trouble regulating their body temp after procedures. This could be a hyper or hypo situation. CV, GI, we worry about an ileus in particular, leading to a bowel obstruction. Anytime we use anesthesia, that slows everything down. Remember, that also has a negative effect on the bowel. So we want to make sure that we have bowel sounds, that our person's passing gas, that we are not worried about a bowel obstruction. And then, of course, skin, which we have talked about. This is straight out of the book. This talks about the fact that 7 to 15% of patients who undergo surgery will experience a post-op complication. That's a pretty big number, right? That is a pretty big number. And if you really think about it, it is up to us nurses to be monitoring our patients for signs and symptoms of these complications. And it can be a minor change in temperature or vitals, or return to level of consciousness, right? It can be something minor. Um, but it is up to us to really catch these changes, these signs and symptoms, and let somebody know, let the physician know. If you like a table, page 343, table 17.2 lists out potential complications in the PACU. So our nursing assessment, all the things we've been talking about, right? Nothing new there. Here is a picture of dehiscence, and then evisceration is where you actually have like an organ poking through. And as you may guess, that's not good. Okay. So that's just a nice little visual there for you. PACU nursing actions. We're going to do all the monitoring. We're going to do all the documenting. We get handoff from the OR. We medicate per order. We maybe request other medications if we are noticing that something's not working for our patient, or we think something would benefit our patient. You know, we can make that request of the physician. And then if our person is transferring from PACU to inpatient or another facility, we may do handoff as necessary. PACU teaching. There's a lot of teaching related to PACU, and a lot of times this is going to be to family members or support system, right? Because remember, our patient, even though they're in PACU and they're clear for discharge, they were just under anesthetic. They are also likely still on pain meds. So their memory and their ability to learn and take in that information may not be all it could be, right? So a lot of times we're going to be doing this teaching to family members. So we are going to be providing written instructions, verbal instructions. A teach back method is always good. And this just also talks about allowing visitation per facility. One of the things that the book talks about that I thought was interesting is also checking with your patient. This would be during the pre-op time period, but what do they want for visitation? Just because your facility says the entire family can come back, is your patient okay with that? Or do they maybe just want their significant other or whatever? So that's all the things we're going to talk about. PACU to inpatient care. So this is our person. They are transferring from PACU over to the inpatient facility. You're going to get brand new orders from your provider. Okay. So then it is going to be the responsibility of the inpatient nurse to make sure that all of those orders are in, that, we've talked about med reconciliation before. If my person is going to inpatient care, I'm not only going to have to make sure that they have their pain meds and everything that they need, but all of their at-home meds, their scheduled meds are in the EMR and available. I'm also going to redo my head to toe because I am re-establishing a baseline. What condition am I receiving this patient in from PACU? Okay. And then at some point, I'm going to go look back and see how that compares to the baseline in pre-op, right? This is my criteria for discharge from the PACU. This is the Aldrete score. This looks at activity, respiration, circulation, consciousness, and oxygen saturation. We have talked about this before because even if you are doing a bedside procedure as a nurse, you're going to get the Aldrete score on your person, okay? This talks about handoff care, PACU to inpatient unit. I mean, you're giving report. The only difference is your person had surgery. So you're going to want to know stuff like how did they handle anesthesia? How long was the procedure? Were there any complications, blood loss, right? All of that sort of stuff. So it's our usual handoff report, just now the things that you're thinking about related specifically to the procedure. Post-op complications related to respiratory, you can get atelectasis. This atelectasis is the collapse of the little alveoli. And if those little alveoli collapse, we're not having adequate gas exchange. Okay, on an X-ray, it looks like a whiteout because all those little tiny grape guys have just collapsed down. We run the risk of pneumonia. We run the risk of a pulmonary embolus. We want our person doing deep breathing, coughing, and centospirometer. We want them up and moving. Um, remember that our first sign of hypoxia is restlessness and anxiety. Pulmonary embolus, you're going to see difficulty breathing, and possibly chest pain with that. Okay. And we're still going to be monitoring our people. They're going to be on a pulse ox. They're going to be on cardiac monitors. And we're going to be watching those monitors and comparing what the readings of those monitors are to what our person looks like, right? Like if my pulse ox is telling me my person is at 98% O2, but my person's lips are turning blue, what am I trusting? I'm trusting what my person looks like, right? So remember, when we are monitoring and assessing for any of these complications, we are comparing our person to our monitors and we are trusting what our person looks like. Okay. Post-op complications, CV, neuro, cardiovascular. This can be related to fluid and electrolyte imbalances. Is my person hypovolemic? Do they have a potassium imbalance? What is going on with them? This can be related to surgical fluid loss. My person could be hyperglycemic post-op. Simply because of the stress of the event. Maybe they are not diabetic, but the stress of surgery, of being in the hospital, the body responds really weird. cortisol release related to stress. Your person can end up hyperglycemic even if they have no history of diabetes. So we're going to be wanting to check blood sugars. Um, Neuro, we talked about neuro earlier. Delirium, cognitive decline. If they were ANO times 4 before the procedure, are they ANO times 4 now? What is going on with them? Excuse me. GI, I worry about ileus. That's going to be a problem for bowel obstruction. We talked about that. If my person has nausea and vomiting, if their abdomen is distended, anything like that, we may want to place an NG for decompression. You know, that may be something, if it wasn't ordered initially, that we may ask the physician about, right? GU, we worry about opioids and anesthesia on the bladder, right? Because, don't forget that all of those medications, especially if our person was under a general, they affect all the muscle systems, and that includes being the bladder. So my person may not be able to pee, right? Also, immobility immobility works against the muscles returning to normal function. So the quicker I can get my person up and moving, the better chance all of the muscles have of going back to normal. Okay. And then of course we worry about skin complications. These are some drains that you're gonna see. A Jackson Pratt looks like a little grenade. A Hemovac looks like an accordion, right? And then your Penrose just kind of sticks on in and drains straight out. It's just a tube. Um, I am most familiar with probably the Jackson Pratt is what I saw most often. We would get patients with Hemovacs as well. Kind of the interesting thing is you only let these guys get about half full. You empty them, and then after you've emptied them, you compress them again. So like the Jackson Pratt, it just kind of fits in your hand and you compress it again, and then it will fill, gets half full, and then you empty it again. Same with the Hemovac. That's like an accordion, so you just press it back down, right? After you empty it. I will tell you from experience, the biggest thing after you empty your drain is make sure it is really closed. Because if your drain is not closed, it is going to leak all over your bed. Okay? All over, let me tell you. Not fun to change, not fun to discover, embarrassing. Okay? So make sure after you empty your drains that they really are closed again. Inpatient RN assessment. So we talked about this. We get our person from PACU. We're going to go back to our complete head to toe. We're going to look at all the drains. We're going to assess pain. We're going to run the labs. I want to know what fluids my person got. I want to know what their electrolytes, sugars look like, all the things. Okay. Actions. What are we gonna do for our person? Same old, same old. Respiratory care, fluid management, mobility, DVT prophylaxis, SCDs. Make sure our person is mobile. Um, I don't one of the things with DVT prophylaxis that the book does talk about is not putting a pillow or anything behind the legs, like compressing at the knees, basically, because I run the risk of obstructing normal flow. So just making sure that everything, my person has good positioning. Pressure injury prevention, fall precautions, bowel care. If my person still has a Foley, do they really need that Foley? Maintaining a Foley in place, it's nice and convenient, but it also really increases our patient's risk for infection, primarily a UTI, and then of course it can go to something um, something bigger, broader, if it gets out of control. So we want to assess whatever lines and tubes our person has in place, and do they still need those lines and tubes? Again, with our patient education, we're going to orient our patient to the unit, talk about safety things, talk about the discharge plan. We're going to talk about pain again, right? What's our plan related to pain? We're going to let them know, is PT going to come work with them? OT, speech, whatever the case may be. If we have to do dressing changes, what does that look like? Can we pre-medicate related to that? You know, all the things. The best plan of action is to make sure that your patient is aware of what is going to be going on throughout their stay. And probably a family member as well, because again, remember, our patient is probably on pain meds. So we're going to want to keep family updated as well. This is just a box talking about home discharge instructions. Nothing Nothing crazy, all the things. If they are going to have to go home with dressing changes, we make sure they have supplies. We make sure that they know when to call the physician. We talk about dietary restrictions, activity considerations. Maybe they're not allowed to go swimming. Maybe there's weight restrictions related to lifting, stuff like that. We want to make sure that they know when and where to follow up. Who do they contact? And then if I have somebody who needs to return to work or school, what does that look like? Do they need to have something signed? Do they need to be so many days out? Whatever that may entail. So really post-op, not very complicated. It's kind of all the stuff that we would do anyway, and now we've just thrown in some surgical considerations, right? So that is it. This is a nice short one. All right. So Professor Catabay will be doing module 2 for you, and I will talk to you guys again in module 3.